Thank you very much to Dr. Fries for giving me the opportunity to give this talk.
Oh, gorgeous.
So the patient I want to show is a female patient, 89 years old, had a left hemispheric stroke, arrived at the ER at 9:26. IV lysis was started. The call from the neurologist came at 10:25 a.m. The left internal carotid artery was occluded, and the arrival at the cath lab was at 10:30 a.m. and the puncture of the right femoral vein artery at 10:35 a.m. So here you can see the angiogram of the aortic arch. It's a difficult aortic arch type 3. Here you can see kinking of the left common carotid artery. So the question was how to get access in this patient. So first this was tried via the femoral axis using a SIM3 catheter. However, no catheter or wire could be advanced any further into the left carotid artery. So what to do at this point? It was decided to do a direct puncture of the left common carotid artery using a 4 French radial sheath, and this was exchanged for a 6 French sheath. So the access was the challenge on its own. This was all had to be done under time pressure, so every minute, every second counts. The patient was unconscious, so not cooperative, and was moving around. Somebody had to hold the sheath in place the entire time, and there was no assistant and only one nurse in the cath lab at this point. Here you can see kinking of the proximal internal carotid artery. And here you can finally see the angiogram showing an occlusion of the distal internal carotid artery. So you can see the internal carotid artery being straightened by a wire and a microcatheter. And a Sophia 6 French aspiration catheter was advanced into the distal internal carotid artery. And the aspiration catheter was then advanced into the clot, but nothing could be aspirated at this point. Then a 6 mm by 4 cm solitaire was placed, and the removal was done under aspiration with the aspiration catheter. And here you can see the result of what was removed. So after the clot removal, the blood pressure suddenly dropped to 60 millimeters of mercury. And here you can see the ECG that we saw on the screen. So the CPR team was alerted at this point. The patient had to be intubated and ventilated. And here you can see the coronary angiogram using the sheath in the groin. And you can see a tight stenosis of the right coronary artery right here. Maybe it was a clot. It does not look like a typical clot. Here you can see the implantation of a 4 mm stent. The ECG at this point and the blood pressure came back to normal. So looking back at the brain at this point, the internal carotid artery was open, the anterior cerebral artery was open, but the middle cerebral artery is still occluded. This is the angiogram 2 minutes later. So the middle cerebral artery is open, but there's still a stenosis. And what else is not good at this point? You can see it zoomed in a little bit here. There's a stenosis or a clot in the distal internal carotid artery. So the question at this point, again, just as in the heart, is this a stenosis or a clot? 2 minutes later, this was the angiogram. Oh, sorry. And you can see again an occlusion of the middle cerebral artery.
You need to plasty this. You need to do the same.
So this is the placement of a 6 mm by 4 cm solitaire. And you can see that immediately flow is restored.
Just stent or just a PTA?
And this is the angiogram after removal of the solitaire and the aspiration catheter.
But here you've already put a stent here.
The puncture sites at this point were closed using angioseal, and looking back at the heart, the left coronary artery also showed a stenosis of the diagonal branch and was decided to use medical treatment at this point. So at our center, this was the first direct carotid puncture for acute stroke intervention, the first direct carotid puncture under systemic lysis, the first acute myocardial infarction, which happened during acute stroke intervention, and the first stroke patient that really needed intubation. It was the first stroke patient needing CPR and the first CPR with a sheet in the common carotid artery and a catheter in the brain. The key changes for us after this case were that we almost routinely use a combination of aspiration catheter and stent retriever, and we more often use the direct carotid access for both carotid stenting and acute stroke interventions. but we do not routinely plan to acute MIs during stroke interventions. Thank you very much for your attention.